webinar series. My name is Elspeth McSorley, and I'm very excited to welcome all of you, and I'm happy to have so many of you joining us today. Today we're focusing on the science behind the PainCAS clinical assessment system. Just to review the purpose of the PainEDU webinar series, this is a new way for us to be communicating with the PainEDU community. We'll be sharing information and letting you know what we're developing. We'll be presenting pain-related topics that we hope you find engaging and relevant. And this is also a chance for you to ask us questions and interact with us. Just to go over a few webinar logistics and a little bit of housekeeping, please have your telephone, you're using your telephone for audio, and please have it muted at all times. You will not be able to use your computer's microphone or speakers. Also, please don't put your phone on hold, just in the chance that there's any hold music playing in the background. We don't want that broadcasted for all attendees. And we'll be answering all questions at the end of the presentation. This image is just what you should be seeing on your computer screen. Again, please select telephone. You must call in, use telephone to listen into this webinar. And below you'll see a chat and questions section where you can write in questions during the presentation. But again, just remember we'll be answering them at the end. And the availability of today's presentation. After the webinar, you'll be getting an email, and with it there'll be a link to view a recording of the webinar. We will also have all the presentation slides available, and all the scientific posters that you'll see during this presentation. Those will be included as well. I would now like to introduce you to Siddharth Charity. Ms. Charity has managed the PainCAS program development over the past several years, from initial prototyping and feasibility studies to launching the completed program and conducting an efficacy study across multiple clinical settings. Ms. Charity has a background in managing healthcare and education grants and has worked on the development and testing of other web-based solutions in areas such as chronic pain and substance abuse. I would also like to introduce you to Kevin Zakharoff. Dr. Zakharoff is a licensed board-certified anesthesiologist with more than 25 years of clinical experience in anesthesiology and pain medicine. He is the Vice President of Medical Affairs at Inflection, an active faculty member at the State University of New York Stony Brook School of Medicine, a member of the Board of Directors of the American Society of Pain Educators, and the Medical Director of PainEDU, our website for healthcare provider education, and PainAction.com, our website for patients with chronic pain. Dr. Zakharoff is co-author of a number of our print publications, including the PainEDU Manual, a pocket guide to pain management.
Thank you very much, Elspeth, and it's a pleasure to be speaking with you all today. And before we get into the science of PainCAS, I'd like to just take a moment for those of you who might not have been able to attend our last webinar and just talk about PainCAS for a moment and give you some background information. PainCAS is basically an electronic tool that we design for assessing patients who have a chronic pain problem and also assessing opioid risk really related to aberrant drug-related behaviors in chronic pain patients. As you can see by the image, our goal was to try and make this as portable as possible and easily accessible as possible. And when we get into the science of how we develop the tool, we'll delve into that a little bit more deeply. Our thinking from the perspective of the utility of PainCAS has always been from a clinical perspective. We have from the beginning thought about PainCAS as not only a tool that could serve a lot of purposes with respect to workflow, with respect to accessibility and other different aspects. We've always had in mind the idea that we wanted to make a difference at the clinical level. And with that in mind, when we first started thinking about developing this tool, we thought about the utility of standardizing assessments in a clinical setting. We thought about taking the assessments that now often exist on a clipboard in a paper and pencil format and replacing them, not only with an electronic document that could be easily inserted into an electronic medical record, but also with the intention of having it create a standardized output document that clinicians could refer to very easily in a facile way. We also knew from our backgrounds and prior research that we've done, and also discussions with experts and non-experts across the country, that whether it's due to educational deficits, lack of time and resources, or a variety of other reasons, that there's often a lack of communication between patients and their healthcare providers. And we really wanted to try and develop a tool that could encourage dialogue and transparency and communications. And one of the ways that we did that, for those of you who weren't on our last webinar, is by having the output of PainCAS be in a report format, a report available for clinicians and a separate report available for patients, with the intention of the patients and the healthcare providers being able to discuss what the reports are showing and the results that the reports are providing. We had to think about the fact that an electronic format would allow people to improve the documentation that takes place when chronic pain patients are assessed, whether it's being just assessing them for pain or assessing them for risk of aberrant drug-related behaviors. And from a workflow perspective and a streamlining perspective, and lastly an efficiency perspective, having a capability of patients to complete this assessment for those who had access to the internet and email addresses, the ability to complete it before they ever even ended up in the clinical setting. So one of the things that we got asked a very large number of times after our first webinar about PainCAS was requesting the scientific information. We had so many requests from people about the science behind PainCAS and about how this was developed and what was the science behind it, that it actually set the stage for this webinar today. So the first place that we'd like to start is with our initial goals when we were really at the brainstorming stage. We knew we wanted to replace the paper and pencil assessments. We knew that there was a high level of variability in the way that patients are assessed, even within a given clinic setting. So standardization was definitely something we were looking to achieve. There's been a lot of interest on PainEDU and certainly a lot of information in the literature about our opioid risk assessments, the screener and opioid assessment for patients with pain, or the SOAP tool, and the current opioid misuse measure, or as we call it, the COM tool, which live on PainEDU.org. But there's been a lot of back and forth discussion in many cases about how to weave the use of these opioid risk assessments into the pain assessment process without doing what people often say is yet adding another form into the equation. So we very early on made the decision that we were going to weave the SOAP and the COM into the PainCAS assessment to solve that problem and not have to have people think about it so much. As I mentioned before, it was very important for us to try to improve the level of communication and transparency between patient and healthcare provider. One of my favorite lines when I'm speaking on this subject is the fact that if both the patient and the healthcare provider don't have any idea of what the goal of pain treatment is, it's going to be very hard for both of them to ever realize if they achieve that goal or those goals. And we wanted to try and have PainCAS provide the platform for that kind of dialogue and communication and goal setting to take place. We certainly understood at the early stages of this that there were going to be benefits to implementing a tool like PainCAS in clinical settings, and there were going to be barriers to implementation. At Inflection, we have a lot of experience in this area with other electronic tools, and we've learned a lot, and what we wanted to do was make sure that we didn't overlook these things along the way. And Sadaf is going to be speaking about this a little bit later on in the presentation, but we went in eyes wide open, and we wanted to tackle that head on. We also understood that there was going to be an impact on clinical workflow, and we took painstaking steps to make sure that we understood what those impacts were, and along the way in the development of the tool, that where certain challenges to clinical workflow were identified, that we changed them before the tool ever reached the finish line. It was very important for me personally to be able to provide assessments for clinicians in the clinician report that put the pertinent positive information right up front for the healthcare provider to view. I know from my years of practice, what typically happens is when patients fill out that 100 or plus set of questions in their assessments, it often ends up in a little holder outside of the examination room, and then as the healthcare provider is walking into the exam room, they start glancing at answers to certain questions, but in no way could there possibly be the ability in that short period of time to really have a sense of what's going on with the patient. And this was a real personal goal for me, was to push the pertinent positive information up front, still have the documentation of all of the answers to all of the questions there for both review and documentation purposes, but to not have to make somebody read within normal limits for the things that weren't necessarily going to be pertinent to decisions or evaluations that were going to be made at that time. And I'm hoping that many of you are nodding your head yes at this moment. Lastly, we realized that as we are in 2014 and everybody else is moving towards electronic medical record systems, and we hear terms like big data being thrown around almost on a daily basis in every aspect, including healthcare, we wanted to change the paper and pencils assessment and its capacity to provide data for evaluation and also outcome measurement. It was a very big impetus for what we were really trying to do. We wanted to try and move into an era where we could answer a lot of the unanswered questions, if you will. Sadaf?
Yes, thank you, Dr. Zakharoff. As you mentioned earlier, the development of PainCAS has been supported with 2 NIH grants, specifically from the National Institute of Drug Abuse. These grants have spanned about a course of 6 to 7 years. They started back in 2008, and we'll be wrapping up our Phase 2 grant early next year in 2015. In the following slides, Dr. Zakharoff and I will be giving you an overview of the studies we completed during this time and how they informed the PainCAS program and its development over the course of that period. Both grants had a panel of 8 consultants that came to us from many different organizations. They had a variety of backgrounds, specialties, and disciplines, and included both pain management experts as well as primary care clinicians. Some of these consultants have since moved on to other positions and organizations, but this slide shows where they were at the time of the grants. The consultants also played a big role in the development of the assessments themselves and the questions and the reports. During the Phase 1 specifically, we developed a prototype of the PainCAS program, and we completed feasibility testing of this concept of electronic pain and opioid risk assessments. We were able to go through a multi-step process to determine what the domains and topic areas of the initial and follow-up pain assessments would be. And we also spent a lot of time thinking about the format and the content of the clinician and patient reports that the program would produce. We also completed acceptance testing of the program and also validated electronic versions of the opioid risk assessment.
And one of the questions that I get asked often with respect to PainCAS is, how did the assessments get created? A lot of people think, did we just sit down and say, well, these are the questions that we thought that every pain assessment should contain? And we spent a tremendous amount of time going back and forth about this. And our approach to this was a scientific one. We used a process called concept mapping, where we had pools of questions and topics with the scientific methodology of allowing us to ultimately shrink the assessments into specific domains within which there would be specific question sets. And I don't know how well this is viewing on your screen. This is really just a graphic to shore up what I'm saying. You will have access to these slides, as Elspeth mentioned, at the end, so don't worry if you can't really read it, but I'll just briefly touch upon the fact that what we did settle on were 8 clusters or domains that we used for the initial assessment, starting with pain characteristics, medical history and other symptomatology, medication history, substance abuse history, social history and functioning, psychological history, current mood and psychiatric issues, and then overall impact on life. And this is for the initial assessment domains. For the follow-up assessment domains, we settled on daily functioning, psychosocial stressors, patient attitudes and expectations, especially focusing on coping, psychiatric questions, medical issues, medication management, and then obviously a pain assessment, which is something that would span both of these. We spent 6 months going through this process, and it's worth mentioning that at the very early stages, and I think Sadak, you'll remember this, we originally incorporated a full medical history into the PainCAS assessment. And we did it because we figured, well, you know, it's probably likely that people would want to know a lot of the answers to these questions. And then we moved away from that only because an assessment like that would have probably taken way too long for a patient to complete. And we ran the danger of giving more information than in some situations that people wanted. So this is really what we settled on. But it wasn't certainly a situation where we just had a whiteboard and we're writing down questions. We really spent a lot of painstaking effort to come up with these assessments.
This is an example of a very early version of the PainCAS clinician report for a follow-up assessment. But it gives you an idea of some of the key things that we were looking for this report to include. One was that we wanted to avoid a situation where a clinician was reading through sentences and narrative sections of a report. We wanted the report to be at a glance, where information is presented clearly and information is also jumping out at the clinician. Specifically, the very high kind of pertinent positive that Dr. Zakharoff mentioned earlier. In addition, we also wanted to make sure that the report was visually showing change over time. So although the report has evolved over the years, and the one that we have out now looks slightly different, it still is true to these main goals of being at a glance, visually showing change, and having critical information jump out at the clinician. This is a poster that we presented on our phase 1 studies and the work that was done during that grant at an American Pain Society meeting. Our acceptance testing results showed that both patients and providers rated, actually 89% of patients and providers rated high satisfaction with the PainCAS prototype that we developed for the phase 1. Some of the benefits of PainCAS that were identified during that phase 1 grant included standardization of pain assessments and also helping healthcare providers identify appropriate candidates for opioid therapy and also, you know, which one of those are at risk for abuse or misuse.
Yeah, and it's worth mentioning that certainly when I think of science, it's not always the case that I think about usability and acceptance testing, but we do often get asked questions about those specific things. How easy is this for a patient to use? What literacy levels are the question sets geared towards? And how easily administered is it for someone to actually complete the assessment through the PainCAS? I was at a clinic setting actually earlier this week, and somebody asked me the question about what if the patient is not able to complete the PainCAS? What would happen then? And my answer to that person was, whatever would happen if the patient couldn't complete the paper and pencil version. It's possible that somebody might need to actually ask the questions to the patient. Hopefully, it might be the case that they might have a caregiver with them that could help them complete it. But it's not as if we overlooked that, and it was a very critical piece of the puzzle, and I think a very important thing that we needed to demonstrate, certainly in the phase 1 feasibility of a tool like this, to the National Institutes of Health in order to get that second grant. Sadaf touched on this before, but I think it's an important topic to spend a moment on. This is a poster that we presented at another American Pain Society annual meeting. We very often get calls from people with respect to the SOAP and the COM tools. And Dr. Steve Butler, along with Dr. Simon Budman, back when they were developing the SOAP and the COM tools, they went through a lot of time and energy to make sure that these tools were valid. And they also had the foresight through other research to know that it's not necessarily the case that when people are answering questions to a computer that they answer them the same way they might to another individual or even on a paper form. So when we get requests from people to develop their own versions of the SOAP or the COM, we tell them about PainCAS. We generally do not give them permission to do that. The SOAP and the COM both are proprietary tools that require licensing for anything more than an individual clinician. And Dr. Butler, the primary investigator on this grant, actually brought up the idea that we needed to take the steps to make sure that the SOAP and the COM tools were valid when patients were taking them on a tablet or by a computer, and we did just that. So for those of you who are interested, when you get the PDFs, you might be interested to see the results of this validation. But both tools have been validated in the electronic form of the PainCAS.
Here's another poster that we had presented also at another American Pain Society meeting. This poster is presenting a survey we had done with 79 clinicians on their perceptions of what an electronic opioid risk assessment tool would mean for their practice. The survey covered topics such as, what technology are their practices using now, what are their current processes with the paper versions of the SOAP and COM, and also, how they felt that the electronic versions would impact their practices in terms of benefits and barriers. Our survey results showed that clinicians felt that workflow would either stay the same or improve with the move to electronic formats for these assessments. And some valuable features that were highlighted through the survey were the fact that scores would be automatically calculated for the SOAP and COM, that the reports that are produced would offer monitoring recommendations based on the patient's risk level, and also that would offer the opportunity for patients to complete these assessments outside of the clinical setting before they even arrived for their appointment.
Yeah, and I think it's also worth mentioning the fact that what we found that people tend to do with the paper and pencil versions is they have patients fill it out, and then it's somebody's job to then scan it in to a PDF form and then be attached to the medical record. Or they have someone actually transcribe it into another system to capture all of the answers to all of the questions, to then manually score it, and obviously there are no monitoring recommendations included with that. So in terms of workflow, we were very hopeful that we would be improving efficiency and improving workflow with that respect. And moving on to a poster that we presented at the American Academy of Pain Medicine, when we were in the course of developing this tool, we came up with the notion that what we really should do is we should create a beta version of this, test it, and see if it really lived up to what we were hoping at that stage of the game it would. And our hypothesis was a really simple one at first. We really only wanted to follow the track of the opioid risk assessments. It's not a coincidence that Sadaf mentioned that we wanted to see what the perceptions were about an electronic version of an opioid risk assessment, because we didn't want to presume that everybody would be willing to move from their current assessment for pain patients to a new assessment. So we just focused on the opioid risk assessments themselves. And our hypothesis was to look at how often institutions that had made the philosophical decision that they were going to use opioid risk assessments, namely the SOAP and the COM, how often did those actually end up in the medical record? We also, as a hypothesis, wanted to look at impact on workflow, and we made sure to look and do this beta testing at two different flavors of clinical settings. One being a very large pain clinic at a highly academic, well-known institution, and the other a more private, interdisciplinary pain clinic. So we could look from both sides of the fence. We gathered a lot of information from the workflow perspective, and we found information that helped us think about what we could do to improve the presentation of the assessments and the reports and make it easier for the administrative staff to access them. We received input about the possibility of sending reminders to patients to complete the assessments when they're supposed to before they come for their visits. Things like having the individual healthcare provider in a given setting attached to the individual assessments, so everybody would know this is Dr. Zakharov's patient or this is Dr. Charity's patient, and so on and so forth. So we looked, and what we found was that in the two settings that were using paper and pencil versions of the SOAP and the COM, only roughly about 40% of the time were the assessments actually ever making it into the medical record. And when we did the beta testing, after we did the chart review to see what that incidence was, and then we implemented the beta test, what we found was the likelihood doubled and went very close to 79 to 80% of the time that the electronic medical records ended up in the medical record. And for all of you who are out there who are aware of all of the controversies that are occurring right now in the pain management world, you all know that documentation is something that everybody is very interested in. And I would posit that having an opioid risk assessment as part of the medical record in 2014 or some notation about it is at least standard of care.
In one of the earlier slides where Dr. Zakharov was presenting our initial goals with PainCAS, he mentioned the data that the system would be producing and the opportunity to look at outcomes based from that data. In order to understand that value of the data that PainCAS would be producing, we did a series of interviews with clinicians and clinic administrators that we presented in this poster at a Pain Week conference. What we found through these interviews was that the PainCAS data would be very valuable to clinicians and clinical administrators. And we found that there are several ways that this data would help those groups inform their clinical decisions. Such things as treatment planning and treatment services justifications, evaluating clinician performance, guiding staffing and program development decisions, as well as an opportunity to look and track changes over time, or some of the ways that this PainCAS data would be helpful to clinical settings. So right now we're in the process of wrapping up our Phase 2 grant, which will be ending in early 2015. The goal of the Phase 2 grant was to build the PainCAS program and to test it in clinical settings. During the last couple of years, we finalized all of the questions that fell into those 8 and 7 domains in the initial and follow-up pain questionnaires, with input from pain patients as well as our consultant panel. We did a series of cognitive interviews of the PainCAS assessments with chronic pain patients to make sure that the final versions of these assessments and the questions, the responses, would all be easily understood by patients. And after those interviews, we went back in and did some revisions to change words and language to make sure that the comprehension of the assessment was clear by all patients. The program itself launched in March of 2014, so just earlier this year, and also at the start of the year, we launched our Phase 2 efficacy study.
And that efficacy study is actually ongoing right now. The primary outcomes of the study is to look at a patient-reported assessment content discussed during the visit with the provider. So you might recall earlier on in the webinar, I really drove home the point about transparency and communication. What we really wanted to look at and see was that in the non-experimental condition, were things getting discussed between patients and their healthcare providers? And was that discussion rate different than the experimental condition when they were using PainCAS? I.e., was PainCAS more likely to promote discussion about certain topics between the healthcare provider and the patient? And the thing that pops into my mind is people who are in the social sphere of the patient, for example, who have a history of past or current substance abuse, just as an example, history of smoking, alcohol consumption, a lot of things that might not necessarily get discussed between the healthcare provider and patient if they were just answered on a paper form. The other thing that we made a very large outcome as part of this study was, again, what impact would this have on documentation in the medical record, hoping that it would be positive. And it's definitely worth mentioning again that this is to satisfy the Phase 2 grant for the National Institute of Drug Abuse at the NIH. The product has been commercially available since March of this year. So in no way does the outcome of this research preclude a clinic setting from using it. If anything, users of the program are going to be the first people to hear the findings that we discover from our research. The 3 sites that we're doing this study at are the Brigham and Women's Hospital in Massachusetts at the Pain Management Center, Newton Wellesley Hospital in Massachusetts, a large community hospital, and we are doing this study with the primary care pain service there. We wanted to make sure that we were well balanced in the expert and the non-expert arena with respect to our research findings. I'm sure pretty much all of you know that the similarities between a pain management clinic and a primary care clinic are vast, and there's very little similarity. And then lastly, the University of Mississippi Medical Center, and that's in the Department of Family Medicine, so we could really get a good smattering of a sense from people in a variety of different settings with respect to our primary outcomes and have it be as balanced as possible. So I think before we conclude, it's worth sharing with you some other additional findings. If you think back to when I was talking about our brainstorming days, we used to have a lot of discussions about where the PainCAS's sweet spot would be in terms of its utility. Would it be a pain clinic? Would it be a non-expert setting that's basically primary care? Would it be in an institutional setting? You know, we could make arguments about different aspects of all of those clinical settings. So I'll just run through some of the things that we found along the way over the course of the last 7 years. First thing would be with respect to pain clinics. We definitely found that PainCAS is sort of a no-brainer for the pain clinic setting because nobody has to think, does this patient need to get an initial pain assessment or a follow-up? Every patient is getting a pain assessment. So in the case of a pain clinic, it's just a matter of what format is the assessment being delivered. We also found out from experts that they were very much less interested about being given guidance about what to do, but they definitely were interested about things that could streamline the process, very interested about the fact that it had remote capability, very interested about the data, and not so much about what to do. On the non-expert side, the exact opposite. They were not only interested about being helped with deciding what to do, but they were very interested about being given guidance about what questions to ask, how to digest the answers to those questions, and how to sort of debunk the ball of string that is often attached to a chronic pain patient. If we look at the expert pain settings, and those are really sort of the satellite expert pain settings that aren't a full institutional pain clinic, I think they were among the most enthusiastic because it fit within the paradigm that they needed to satisfy in order to do what they did. And there wasn't a high level of bureaucracy that needed to take place in order to implement it. I think where we were surprised a little bit was in the interest at the managed care level. We know, and it's been well published, about the economic burden of chronic pain in our country. And we also know about the increased cost to the system that people who abuse and misuse their prescription pain medications cost to the system. What we weren't necessarily aware of was the idea that there was such a lack of standardization that at the managed care level it was very difficult for them to do chart reviews. Because even within a given clinic setting, different clinicians would have different documentation. So it was very difficult to compare apples to apples. We've also heard from a pharmacy level, and I think we all realize the fact that the pharmacy is playing an ever-increasing role in the management of chronic pain, that there was interest at that level in terms of what could be done to help stratify risk and how to help healthcare providers who were strapped for resources make more educated decisions. Insurers, I would say that it's very similar to managed care organizations, except for the fact that we didn't realize that there are other types of insurers other than managed care who would also be very interested in a tool like this to help them evaluate what they're doing for their patients, and that would include insurers who are involved, for example, in workers' compensation, and disability insurance, etc. And then lastly, hospital systems. We have this discussion here all the time. It's a little bit of a Groundhog Day phenomenon, I call it, where the same thing is happening everywhere. Hospital systems are, in the face of HCAP scores, in the face of the Joint Commission Sentinel Alert from August 2012, clinicians from the perspective of regulatory scrutiny, everybody is being challenged in one way, shape, or form to have a framework within which they reproducibly provide care to patients and measure outcomes. And hospital systems rise to the top of that group. So in summary, I hope we've given you a good sense of the 7-year process we've been through from a scientific perspective about PainCAS. Certainly, we just gave you a smattering of the scientific presentations that have taken place around the country. The IASP meeting is taking place, I believe, next week, and there will be a presentation by Dr. Bob Jameson there about PainCAS. It's important for us to make sure you know that science was incorporated into the development of this program at every step of the way and at every phase, and that we gave consideration to what the needs of the healthcare providers were as well as the needs of the patient. And if you did not get a chance to see or participate in the initial PainCAS assessment, I highly recommend you find the archived version or write to us so you could get a much better idea about the different aspects of the tool. Just again, to let you know that it is commercially available now. It is in use in a number of clinical settings, but that does not mean that the research stops here. The research will continue long after the grant is done, because we are hoping to answer a lot of questions that still remain in the area of managing chronic pain. I just want to take a quick moment to call out credit to the remainder of the scientific team. There are a lot of people who aren't a part of this webinar who played a huge role, and that obviously would be Dr. Steve Butler and Dr. Bob Jameson. Elspeth, who is our moderator today, has made this all possible, and we wouldn't be anywhere without our research coordinator, Christina Loos, to help us make sense of all the data we get. So I will stop there and turn it over to Elspeth now to field some questions you might have in the remaining 10 to 15 minutes or so that we have. Thank you very much.
All right, excellent. Thank you so much, Dr. Zakharoff. We had a question that you actually just answered, but I'm just going to read the question and answer it because we did have a couple of them. So when will PainCAS be available? Again, it is available right now. Let me see. A lot of questions are coming in. Next question. What will be the clinician burden if PainCAS is implemented?
Yeah, so this is a question we often get asked, and I was asked this question this past Monday by a very enthusiastic emergency department physician. Being a physician myself, our goal and my stake in this game was to make sure that there was zero burden on the clinician with respect to PainCAS. I would say that from an implementation perspective, the majority of implementation will be achieved, and I think you agree with me, Sadaf, at the administrative level. Yep. We didn't cover it today, but there is a dashboard that is provided as part of the PainCAS program that is the mechanism by which people get access to the reports and send assessments to people or give someone a tablet to complete it in the waiting room. But none of that has anything to do with the clinicians. The clinicians' interaction with PainCAS is at the point at which they pick up the report and see, hopefully, the pertinent positive information in front of them, or are able to more quickly digest what's going on than if they were using paper and pencil. So hope that answers that question.
Okay, excellent. Thank you. Another question is if you could just explain a little more about how PainCAS would streamline the workflow.
So, yeah, I didn't want to go into too much depth at this during the presentation, but we have hundreds, if not thousands, of of clinical settings around the world that use the SOAP and the COM tool. And the only ones who use it in an electronic form are people who are PainCAS customers. Along the way, along these agreements where we license the paper and pencil version, we have heard about just about every combination that you could imagine in terms of how the opioid risk assessment ends up getting into the medical record. In many cases, patients are given a paper form to fill out at the beginning of their visit. Somebody has to sit down and then manually score that paper form. The total needs to be there. Somebody then needs to look at the total to see what risk stratification segment the patient falls in, and then look at then what monitoring recommendations were included with the SOAP or the COM for that patient. Now, in a situation where it's filled out in paper form, that then, if it has a chance of getting into the electronic medical record, either is, in almost all situations, scanned in by someone into a PDF form, and then attached to the electronic medical record. The output of the PainCAS reports is a PDF, and the SOAP and the COM scores are automatically calculated, and the risk stratification is automatically assigned, and the monitoring recommendations for that risk assessment stratification are automatically included. So I seem to be using the word automatically a lot, but hopefully that automation answers that question. The other thing to consider is the fact that, in addition to that, if somebody wants to have a look at any outcome data, or even SOAP scores, we've heard people say, well, gee, it would be really nice to know, how do my patients who had moderate or high SOAP scores, how do they end up doing at the end of 6 months or a year? Well, the only way they could find that information is by doing a chart review. And that's too cumbersome to do. So those are ways that it streamlines the process, not to mention the fact that there's no clipboard and paper in this story. And I think regardless of where you live and what the socioeconomic status is of your patient population, I think at this point in time in 2014 and 5 years from now, it's going to be reasonable to think that the majority of the population in this country are going to be quote-unquote connected. And according to Pew Research, somewhere upwards of 89% of them are connected now. So to me, to have that assessment, whether it's the initial assessment or the follow-up assessment completed before the patient ever arrives for their office visit, is a huge streamlining factor. So take it out of the waiting room, put it into the cloud.
Okay, great. Thank you so much. Before I give you the next question, we have just had a number of questions about the webinar. Will it be available, the slides? And I just want to remind everyone, yes, everyone who registered for this webinar is going to get an email, and we'll have links for you to view a recording of the webinar. We'll have a link to the whole slide presentation if you just want to look at slides without the recording, without the voices. And then we'll also have a link for everyone to view the scientific posters. So those will all be coming to everybody on the webinar. All right, let me jump back in to some of our more clinical questions. How long does it take to complete the initial and follow-up assessments?
Yeah, so that was one of our guiding principles back in the early stages of the phase 1 when I was talking about the assessment development. It's very possible that if I had my way, this could have been an hour-long process for the initial assessment. We ended up looking at different versions of paper and pencil assessments, timing how long they would take people to complete, and where we settled was with question sets that would take about 15 to 20 minutes for a patient to complete for the initial assessment, and somewhere around 5 to 8 minutes for the follow-up assessment. So we wanted to make it manageable. You know, again, for any of you who weren't able to attend our first webinar, I highly recommend you watching that first webinar because it drills down into the nuts and bolts of PainCAS. You know, we did go through a lot of effort to make it as easy as possible for patients to complete. But that's about a good assessment, no pun intended, about how long it should take to complete the 2 assessments. It's also worth mentioning that we have spoken with clinical settings who are not interested in having a full pain assessment be administered. And a question I get all the time, I don't know if this is a question you've received today, Elspeth, or what if I just want to give the patient the soap or the calm? You know, what if I have my own pain assessment, I'm very happy with it, and I'm content? And the answer is that PainCAS is modular. We developed it in that way. So if you choose, you could have the pain assessment question set along with the soap woven into it. You could choose to have the soap assessment without the pain assessment question set, and you could do the same thing for the calm with the follow-up assessments as well. And we even give people the choice to determine what version of the soap they would like to include, because we know there are some people out there who feel that I would like to use the short form of the soap as my sort of initial screener, and before I go down the road of using a 24-item soap bar, let me dip my toe in the water with the 5-item soap. So we do give you that flexibility as well. So you can mix and match what you like in terms of that. So it's very possible if you just chose to use the soap 5 that it could take 3 minutes for the patient to complete, or for the soap bar maybe 5.
Okay, excellent. Thank you. Another question that's popped up a couple of times, what if the patient has comments in addition to the assessment set? What if they just, the patient wants to mention something else or get something else across to their healthcare provider?
Yeah, that's a great question. So when we were talking with our consultants that Sadaf identified earlier in the presentation, what we started to hear, and maybe even when we did the beta testing, is very often when people fill out their assessments on paper, there are answers to questions they have that there's no question for. And people would say to us that patients would write up the side, different things that they wanted to make sure the healthcare provider wanted to know. Sometimes patients, and I have certainly seen many like this, bring volumes of information to you. We built in the functionality, once we heard that, into the PainCAS assessments. So we do give patients the availability to enter free text for additional comments that they want to make for both the initial and the follow-up assessment. I don't know off the top of my head. I'm hoping it's limited to like 1,000 characters. It's certainly bigger than a tweet, but we did provide that functionality because we heard time and again that we couldn't be sure that we were asking all of the questions the patient wanted to answer.
Great, thank you. The next question I'm seeing coming up a few times, what is the format of the clinician and patient reports, and will this integrate into my EMR?
Yeah, so there are really 2 answers to that question. So the simple answer is the format is, in pretty much every case, I would like to say a PDF. We did run into one institution that their electronic medical record didn't have the ability to incorporate a PDF. They were only able to accommodate JPEG, but I would say for the masses, it's a PDF document that could be easily attached to any electronic medical record, just like a consult that I might be doing for a patient who is in Massachusetts from my home base, which is New York. The second part of the answer to that question is the question of interoperability. And I have a decent amount of experience in this arena myself. We are not at a place yet where we could develop a version of PainCAS that would be interoperable with every electronic medical record that's out there. I have privileges at 2 different hospitals that are about 8 miles from each other. They use 2 different electronic medical records, and if the patient gets transferred from one institution to the other, the medical record, unfortunately, does not go with them. So our version of interoperability in 2014, until the dust settles a little bit with respect to EMRs and standards, is to create a PDF format document that could be easily attached to any electronic medical record, shortening the steps that somebody would have to take to scan it, score it, transcribe it, et cetera, et cetera.
Great, thank you. I am going to be respectful to everyone's time, and I'm going to end it there. So thank you so much, Ms. Charity, and thank you so much, Dr. Zakharoff. To all our attendees, we hope you enjoyed today's webinar. We would greatly appreciate your feedback, so please take a few minutes and answer the post-webinar survey that you will be emailed later today. Also, if you had any questions that weren't answered, and I know there were a number of questions that came in on price, in our webinar survey, there will be a spot where you can enter in any of your questions, and a PainCAS team member will get back to you. So please feel free to put your questions in there. I'd also like to invite everyone to please visit the PainCAS website at PainCAS.com. We would love to hear from you, so you can also give us a call at 877-207-0645, or feel free to email us at support@PainCAS.com. And thank you so much for attending today's webinar. Our next webinar will take place early next year, so stay tuned for details, and we look forward to having you join us then. Enjoy the rest of your day, and thank you again for joining us.